Okay, so thanks everyone who's with us for joining us for this month's test and prediction seminar, or TAP seminar. So as always, we've just got an hour for the session. So we have David with us today, who will present his research for about 40 minutes, leaving us some time for questions and comments. So it gives me great pleasure to welcome Dr. David Phillippo. Is that how you say it?
That's right, yeah.
Okay, who's our speaker today, who joins us from University of Bristol. He's a statistician and research fellow, working broadly in evidence synthesis. So we're really keen to hear a bit more about your research. So I'll hand over to you, David.
Thank you. Thanks, everyone. Thanks for coming. It's a real pleasure to be with you online today. It's a shame I can't be there in person, but I'll be with you soon. So yeah, I'm going to talk today about multi-level network meta-regression for population-adjusted treatment comparisons based on individual and aggregate level data. And shortly, I'll tell you what all of that means. So let me see slides. There we go. Yeah, so a common scenario that we often find ourselves in is one where we wish to compare multiple treatments, but not all have been studied in the same randomized controlled trial. And so there are some standard methods which are well known in this sort of scenario, where you have aggregate data from say two studies, a study comparing treatments A and B and a study comparing treatments A and C. And you have information on the relative effects from each of these two randomized controlled trials. And then using these relative effects, you can form what's called an indirect comparison. So you can estimate the B versus C relative treatment effect by taking the difference of the AC and the AB effects. So essentially just joining the dots here. Can you see my mouse? Is that coming through? Yeah, perfect. I like to be able to point. So that's a standard indirect comparison. It just relies on published aggregate data from each of these trials. And the extension of this then to larger studies of networks, where you might have more than 3 treatments and more than 2 studies, is known as network meta-analysis. But it relies on this same kind of idea of just joining up the dots. Now, all of these standard methods are assuming something called constancy of relative effects. And that means that the AB effect that we see in the AB study is exactly the same as we would expect to see in the AC study if that study had included a B arm as well. But this assumption breaks down and we incur bias if there are differences in effect modifiers, that's variables that affect how a treatment works relative to control, if there are differences in these effect modifying variables between the study populations. So the idea of population adjustment methods is to make use of available individual patient data, or IPD, to adjust for these effect modifiers and produce a population adjusted indirect comparison. Now, in an ideal scenario, we would have individual patient data from all of our studies. So we would have outcomes for each individual, which treatment they received, and each of their covariate values measured at baseline. And then the gold standard here is an IPD meta-regression. We've got loads of data in every study. We can stick that all in a big regression model and we're away. But in reality, this is often not the scenario that we're faced with. Much more common is that we have limited individual patient data. So we have IPD from one study, but only published aggregate data from other studies. So this might be the mean outcomes on each treatment arm, and then the baseline covariate values. If you imagine that you're a manufacturer, say, of treatment B, and you're making a submission to NICE, say you want them to pay for your drug on the NHS, and you need to compare against your competitor's treatment C, then you might have individual patient data on your own study, but your competitor is unlikely to cough up all of their nice valuable IPD for you. You're only going to have published aggregate data on your competitor's study. So that's quite a common scenario that we find ourselves in things like health technology assessment. So in this mixed data scenario, there have been some methods that have been proposed over the last few years. The most common of these at present is a matching adjusted indirect comparison, or a MAKE, which is a reweighting type approach. So what we're going to do is we take the individuals in our AB study and we derive some weights to balance their covariate distribution with the AC trial. And then with those reweighted individuals, we estimate the outcomes on A and B treatments in the AC study using the weights. So that's a MAKE. There's also a simulated treatment comparison, or an STC, and this is a regression-based approach. So we fit an outcome regression model in our AB study where we have all our individual patient data, and then using that fitted model, we then predict the outcomes that we'd expect to see on treatments A and B in the AC population. And with those predictions, we then form this indirect comparison. So we can either weight into this aggregate population, or we can kind of predict with regression. But there are some limitations of these approaches. First of all, that they are limited to this pairwise indirect comparison scenario. So we've got an IPD study and an aggregate study. They don't generalize to larger networks like we often see in practice. And furthermore, and perhaps more worryingly, the comparisons are also stuck in this aggregate study population. But if you think about making a treatment decision for a population, well, if we're saying that there is effect modification and that treatment effects may vary between populations, then we're also saying that the treatment decisions may vary between populations. One treatment is more effective in one population might be less effective in another, so we might recommend it over here and not over there. So we need to be able to produce estimates that are relevant to a decision target population, and that's not necessarily going to be represented by this aggregate AC trial. So this is quite a fatal flaw, really, for using these methods for decision making. There's also a more technical issue with the STC. Some forms of STC also incur aggregation bias when we have a nonlinear model, because they are just plugging in mean values into this regression model, and that is Jensen's inequality. So you get aggregation bias, and there's also an extra layer of non-collapsibility bias. If you've got non-collapsible outcome measures, so an odds ratio, for example, then you're getting a conditional estimate out of your AB study, and you've got a marginal estimate out of your AC study, and so you're combining apples and oranges. You've not got like with like. So there are some issues with STC. There are some more sophisticated forms of this approach that get around these issues, but if you're using STC, you have to bear this in mind. In larger networks, you can try and use a meta-regression type approach, which is just an extension of the standard network meta-analysis framework. And typically what happens is that you plug in your mean covariate values for the aggregate studies. So in the IPD studies, you fit your IPD meta-regression model. In the aggregate studies, you just plug in the mean covariate values that you had for those studies. But again, this incurs aggregation bias and non-collapsibility bias, so it's not really a good idea. One thing that can be done is you can split the estimation of the interaction terms. So I think this is often done in the prediction modeling literature and prognostic modeling literature, where you have within study interaction estimates and across study interaction estimates. And you kind of split apart these interaction terms. And so your between study interaction terms are biased, they're kind of nuisance parameters, and your within study interactions are unbiased. But the problem with this, for the purposes of population adjustment and actually estimating relative treatment effects, not only are these models less interpretable, what is the effect of mean age on treatment? What does that mean? But they're also not identifiable in smaller networks. And crucially, you can't produce predictions for external populations because you have all these extra nuisance parameters in the model. So that frustrates the use of these methods. So we're kind of left in the scenario where none of the methods here kind of do what we want or need them to do. And that's where multi-level network meta-regression comes in. So this is something we proposed a few years ago now, back in 2020. It's a method that solves many of the issues with these previous approaches. So it's applicable in networks of all sizes. It avoids aggregation bias and non-collapsibility bias, and it can produce estimates in any target population of interest for decision making, which is really crucial. Also, quite nicely, it's an extension of the standard network meta-analysis framework. So if you have individual patient data from every study, then your multi-level network meta-regression just reduces down to this kind of gold standard approach of an IPD network meta-regression. At the other end of the scale, if you don't have any IPD and you aren't doing any adjustment, then it's just a standard network meta-analysis. So it kind of bridges the gap between full aggregate data meta-analysis and full IPD meta-regression. So it kind of fills in that spectrum quite nicely. This builds on some previous approaches. So Chris Jackson and colleagues had some similar ideas in an ecological context where they were modelling ecological exposures by area. And in some areas they had individual survey data, and in some they only had aggregate information. And so they had this kind of hierarchical structure of the data going on. And they derived results for these models with normal covariates and a logit link, where you can actually do some of the calculations by hand. And then Jeroen Janssen in 2012 took these ideas and applied them to network meta-analysis, but again with the caveat where he considered only discrete covariates. And again, that's because you can end up doing the calculations by hand. So that's quite limiting in practice. And just to say that all the methods we talk about today are implemented in a nice R package. So if anything piques your interest, you can go away and have a play. So how does ML-NMR work? Well, first of all, we start off by defining an individual level regression model. And this is exactly the same as the IPD network meta-regression model that we would fit if we had IPD in all our studies. So for those of us in the room who like maths, like me, here is a nice formula for us. So at the individual level, we have outcomes Y for an individual I in study J on treatment arm K. And we have some likelihood distribution here at the individual level. And the parameter of that distribution we're going to model on this transformed linear predictor scale. So G is our link function. Eta here is the linear predictor. And you can see then that we've got a study-specific intercept. That's this mu J. X, this vector is the vector of covariate values for the individual. Then beta 1, these are the prognostic effects of the covariates on outcome. And then beta 2k, these are our effect modifying interactions. So these are how those covariates are altering the effect of treatment relative to control. And then lastly, on the end here, this gamma k is the individual level relative treatment effect. So that's a fairly standard just IPD network meta-regression model. But then what do we do with our aggregate studies? What we're going to do is, in the same way that studies report outcomes that are averaged over the individuals in the population, we're going to average or integrate this model over the aggregate populations to form an aggregate level model. So whereas before we might have had, say, a binary outcome for each individual, now we have, say, the number of individuals in a study arm achieving an outcome or having an event, which now has this aggregate level likelihood. So this theta here might be the mean event probability on this treatment arm. And that is modeled via this integral. So we're taking this model and we're integrating it over the joint covariate distribution, which is given by F. So that's the joint covariate distribution of individuals on that study arm. So you can see we're averaging this individual level model over the individuals in the aggregate study population. This looks quite nasty. So what we do is we throw a computer at it. So we use numerical integration to evaluate this integral. You can do this by hand in some special cases, and that's what Jackson and Janssen did in the past. But in general, we can just use numerical integration, and then that gives us a very widely applicable way of fitting these models. So we choose to use a form of numerical integration called quasi-Monte Carlo integration. For those of you that are interested, we generate quasi-random points from the joint covariate distribution in the aggregate population. Now, we don't have these full joint distributions available because if you've got your trial publication in front of you, you look at table 1, you've got the say the mean age and the standard deviation of age and the proportion of people who have a certain biomarker and other characteristics, but you don't know the full joint distribution and you don't even know the forms of these marginal distributions. So how do you get this full joint distribution? Well, essentially what we do is we just reconstruct it with some assumptions. So we can assume that the forms of these marginal distributions are the same as those in the IPD unless you have better ideas. So if a covariate was normal in the IPD, we assume it was still normal in the aggregate data. If it was log normal or gamma distributed, it's the same, etc. And we can also impose the correlation structure from the IPD as well. And all of this is wrapped up using a copula type approach. And that very flexibly allows you to reconstruct the joint covariate distribution just from those published marginal summaries. In practice, the results don't really depend on these assumptions. So even if you've made some hideous errors here, it actually doesn't really seem to affect the results very much at all. So that's quite good. Once we've generated these points, we then just evaluate the model at each of these points and add them up, take the average. So we've turned this nasty integral into just a summation, into a mean, which computers are very good at. So once we've fitted our model, we then want to be able to produce estimates or predictions of quantities of interest for a target population. And so remember I said the target population, if you're thinking about making a decision, is really important. And this target population may be one of the studies in your network, or it may not be. In fact, it's more likely that it's going to be represented by an external observational study or registry data set. So if you're making a decision for patients in the United Kingdom, there might be a registry database or study of such individuals which you want to produce predictions for. You don't necessarily want to use one of the studies in your network. It could even be that you don't actually have data on this population at all, and you're just using clinical expert opinion to form that target population, and that works just as well. If you have IPD covariate information on this target population, well, then we can just produce predictions for each of the individuals and summarize them for the population. If we only have summary statistics, then we go through this kind of numerical integration approach again. So we generate points from the joint distribution and we integrate predictions over the target population. So we go through that approach again. So some key quantities of interest that we might be interested in are population of average conditional treatment effects. And these are you can think of these as the average of all the individual treatment effects experienced in the population. And this simplifies to just plugging in mean covariate values. So here we have the mean covariate values in the target population P. Here we have the difference in these interaction terms, these effect modifier interactions. And then this is the relative individual level relative treatment effect of B versus A. Often we also want absolute predictions, so we might want average event probabilities. So say, for example, if we're putting these things into an economic model, we might need to know average event probabilities in a target population. And again, this just goes through this marginalization integral, which we can evaluate numerically. So these are just average predictions, so average event probabilities in target population. And with these average event probabilities, we can produce population average marginal treatment effects. So this might be a marginal risk difference, or it might be a marginal log odds ratio, a marginal risk ratio. So these are marginal treatment effects on two treatments in the target population of interest. In a decision-making context, often we're most interested in these absolute predictions. So if we're doing cost effectiveness modeling, then we often need these absolute predictions. Any questions at this point before I move on to an example? It might become clear with an example. No, I've got some nods. That's good. Okay, so let's move on. So an example. Here we've got a network of 6 treatments for plaque psoriasis. We've got 3 IPD studies here in green, and we've got 1 aggregate study here in grey. So the Uncover 1, 2, and 3 studies, we have individual patient data, and the fixture study, we have aggregate data. And we've got 2 different dose regimens of ixekizumab every 2 or 4 weeks versus secukinumab, either 150 or 300 milligrams. We've also got etanercept, and we've got placebo. So different treatments for plaque psoriasis. The outcomes of interest are binary response rates on the PASI scale, the plaque psoriasis area and severity index. And we're most interested, for this analysis, we're going to focus on 75%. So this is success or failure to achieve a 75% reduction in symptoms on the PASI scale. There are 5 potential effect modifiers to adjust for. So previous systemic treatment, duration of psoriasis, body surface area covered, weight, and psoriatic arthritis. Interestingly, in this network, there's also a previous MAKE analysis where they compared this focal comparison of interest, shall we say. So ixekizumab every 2 weeks against 300 milligrams of secukinumab via etanercept. And so they had IPD on this comparison, and they had aggregate data on this comparison, and they weighted these individuals into this fixture population to create this matching adjusted indirect comparison. But there are some issues with this analysis. First of all, why did they choose etanercept? Why didn't they go via placebo? There was also a common placebo arm. And they also threw away all of the information, not only from this placebo arm, but also from this entire IPD study, Uncover 1, where there wasn't any etanercept arm. So they're actually throwing away quite a lot of information here. Not only that, but as I said earlier, they can only get estimates in this fixture population, which doesn't necessarily represent, say, the UK population for rolling out these treatments. And there's also no way to obtain a coherent set of effect estimates for all the treatments here. You can't just do lots and lots of pairwise makes and expect them to all add up, in the same way that you can't do lots and lots of pairwise meta-analyses and expect them all to add up. You have to have a network meta-analysis to get a coherent set of estimates between all of the treatments. So let's look at the results. Here we have the MAKE, the matching adjusted indirect comparison. And the analyses, I should say, they were done on the Probit scale. So these are Probit standardized mean differences. And here I'm presenting the marginal treatment effects. So this is the marginal Probit SMD estimated for that MAKE comparison. So you can see they can only estimate this one focal comparison of interest. Using MLNMR, on the other hand, we can get estimates for any of the treatment comparisons in the network. So here I've got all of the main treatment effects versus placebo, but you can create any of the pairwise estimates between any pair of treatments in the network. And you can see here that we've quite substantially, well, reasonably reduced our uncertainty compared to the MAKE. So before we were just about grazing the null, and here then with the MLNMR, we're using a lot more information. So we are getting some reduction in uncertainty. And also, in general, regression adjustment is more statistically efficient than weighting in general as well. So there's a little bit of a gain here from from using the MLNMR. But we're not just stuck in this fixture population. We can produce estimates in any target population of interest. So here I've produced estimates in one of the IPD studies, for argument's sake. So here are the relative treatment effects in the UNCOVER-1 study population. But as I said, it doesn't have to be one of the studies in the network. You could also produce estimates for an external target population. And actually, in practice, that's what you'd probably more likely want to do. We also fitted random effects network meta-analysis in this network. And you can see here that we've actually quite substantially reduced uncertainty on each of these comparisons compared to the random effects NMA. And that's because we are explaining within and between study heterogeneity and variation. We're not just averaging over all of this heterogeneity and variation in the network. We're actually trying to explain some of that variation. So we get quite substantially more precise results than just a random effects network meta-analysis. So all population adjustment methods rely on some key assumptions. First of all, quite a strong assumption is that there are no missing effect modifiers. So this is the conditional constancy of relative effects assumption. And this is, I guess it feels quite strong. However, it's less strong than a standard network meta-analysis or pairwise meta-analysis, which kind of assumes that there aren't any effect modifiers in imbalance in the network at all, which is even stronger. So we are relaxing that assumption, but we are still assuming that there aren't, we've not missed any effect modifiers. We'll actually see in a second how we can validate that with MLNMR. Secondly, we often also need to make some form of what we call shared effect modifier assumption. And what that means is that the variables, the effect modifiers, the things that alter how well one treatment works relative to control, for a set of active treatments, they have the same effect modifiers and they interact in the same way. So effectively, that the interaction parameters are the same thing. So this is just a simplifying assumption for our model. If we make this assumption, then using make and STC, you can actually break out your estimates out of that aggregate population, and they'll be valid for any target population. They'll be constant effectively over overall populations. And that's because then if you make this assumption and you say that these interaction terms are the same, then when you form that population adjusted indirect comparison, these interactions cancel out, and that's why then you get relative effects that are constant across study populations. In an MLNMR, you sometimes have to use this, particularly in smaller networks, to help identify the model. So if you only have one or two aggregate studies on a certain treatment, then that isn't enough information to estimate all of these interaction terms as well. So you might want to share the estimation of those interaction effects with treatments where you have individual patient data or you have more aggregate studies. But that's not a hard requirement here for MLNMR. This assumption may be valid in cases where you've got treatments that are in the same class, so they share a mode of action, but otherwise it's probably pretty unlikely to be valid. So we'd ideally want to avoid relying on this assumption if we can. As I mentioned earlier, MLNMR is also making some further assumptions about the joint covariate distribution. We're essentially imputing some information about that structure from the individual patient data studies, so the same marginal forms and correlation structure, but in practice this assumption is very weak and it seems to make little difference, even if it's quite badly wrong. Now, using multi-level network meta-regression, we can actually validate these first two assumptions here. So there's no missing effect modifiers and the shared effect modifier assumption. And these two are essentially untestable with make and STC, but with MLNMR, we can try to validate them. So conditional constancy, i.e. unobserved effect modifiers, we can use standard network meta-analysis methods to try and validate this assumption. And that's because violations of this assumption are going to manifest as residual heterogeneity and inconsistency in the network. So the relative effects are still going to differ in some way within trials on a contrast and across the network. So we can use standard NMA methods. We can use a random effects model to detect residual heterogeneity, and we can use inconsistency models to detect residual inconsistency. And when we use these approaches for the plaque psoriasis network, we didn't detect any violations of this assumption. Although it's worth saying, as with standard NMA, that these methods are likely to have quite low power to detect any residual heterogeneity or inconsistency. We can also relax this shared effect modifier assumption. Even in this fairly small network, we actually managed to do this, but we had to do it one covariate at a time. So here I've got, I don't know, they kind of look like Christmas trees, so I kind of want to call them Christmas tree plots or something like that. But here in the purple at the top, we have the estimates of the kind of common interaction terms, so making that shared effect modifier assumption. And then in the green for each covariate in each kind of facet, we have the split effects for each treatment. So here, duration of psoriasis, we have the overall interaction and then the separate interactions for each treatment. You can see that they are pretty similar. Same for most of these. There's perhaps some suggestion that this assumption might be invalid for weight. So it seems like this overall interaction is largely being driven by the ixekizumab treatments where we have individual patient data. There's some suggestion that it might be questionable for secukinumab. I don't know. I'm not a clinician. I don't know if that's something that you might expect, but these treatments do share a mode of action. They are in the same class. So it might be reasonable to expect this assumption to hold. And actually, when we looked at kind of a sensitivity analysis where we relaxed this assumption for weight, it didn't make any difference to our results here. So you can, using MLNMR, you can actually start to try to assess and validate these assumptions which were previously untestable. Lastly, I want to talk about survival outcomes. And this is the most common type of population adjustment analyses. So you get a lot of these analyses in oncology appraisals, for example, and I think it's well over 60% of population adjustment analyses that we've seen so far in submissions to NICE have been with survival outcomes. So what does the data look like? Well, for our IPD studies, it's just the standard survival data. We have individual event censoring times and individual covariate values. And then for the aggregate studies, what we're assuming is that we have individual event and censoring times, for example, reconstructed from the Kaplan-Meier curve. So you can, it's quite laborious, but you can point and click on the Kaplan-Meier curves and digitize those. And there's a nice algorithm Patricia Gaillot developed, which reconstructs effectively the IPD event and censoring times from the Kaplan-Meier curves. But we still only have summary covariate statistics, so overall covariate summaries, because we only are relying on published data here. But we can't fit this MLNMR model that we wrote down previously because we actually can't even write it down. We can't write down the aggregate level model, and that's partly due to the censoring and everything that's going on in here. It really frustrates any attempt to write down this model at the aggregate level. So it motivates a more general approach. What we're going to do to extend MLNMR to survival and indeed to general outcomes is work directly with the likelihood contributions from each level of the model. So we start off again by defining our individual level regression model. And this is just an IPD network meta-regression for a survival outcome with censoring. And the likelihood just looks like this. So this is the standard kind of Cox likelihood, if you will. So we have a contribution for surviving up to time t from the survival function. And then if you experience the event, you also get a contribution from the hazard function. So the hazard of experiencing that event at time t conditional on the covariates. So that's the likelihood for the individual level of the model. And then for the aggregate level of the model, for the aggregate studies, we're just going to directly integrate the likelihood contributions over the joint covariate distribution. So this is kind of taking that integration almost one step up in the model. So we're, rather than integrating certain parameters in the model, now we're just integrating the whole likelihood in one go. And that means that you don't even have to be able to write down what the model looks like. You can evaluate this likelihood numerically using the same approach that we showed earlier, using this numerical integration approach. And the beauty of this is that these survival and hazard functions can be any form at all. So they may be parametric models, proportional hazards, accelerated failure times. They could be something more fancy. They could be splines or piecewise exponentials, etc. As long as you can write down the survival and the hazard functions, you can evaluate this more general MLNMR model. And you can use a similar approach to derive methods and models for other outcomes as well that you might not have been able to write down by hand. So let's think about an example, and I think that's just about me. So here we have a small network of treatments for newly diagnosed multiple myeloma. We have lenalidomide and thalidomide versus placebo. We have 3 IPD studies, lenalidomide versus placebo, plus 1 aggregate study, and 1 aggregate study for thalidomide versus placebo. A Kaplan-Meier curves from each of the studies here are shown on the right. And we're going to fit an M-spline baseline hazard model, so a flexible baseline hazard model using a novel random walk shrinkage prior. And essentially that means that the prior distribution, it penalizes for complexity. So we don't have to worry about specifying the number of knots, the location of the knots. We can just specify some reasonably large number of knots, more than we'd expect to need, and it will shrink everything down quite nicely. So we don't have to worry about overfitting the baseline hazard, essentially. And if we fit this survival MLNMR model, we get the following survival curves. So you can see that it's actually doing quite a good job. It's nicely fitting the observed Kaplan-Meier curves in each of the studies. Phillippo 2014 here, there is some difference, but actually that's because these Kaplan-Meier curves are unadjusted. And so there's some baseline imbalance essentially in these Kaplan-Meier curves, which we've adjusted for in our model that we fitted. The median survival estimates vary by up to a year across populations. So it's once again important which population we're producing predictions for from a decision-making perspective, and using MLNMR, we can get those in any population. And there was also evidence of non-proportional hazards when we fitted an unadjusted model. So where we didn't include any covariates here, we actually observed non-proportional hazards for some of these studies. But even just by including baseline covariate information, that was sufficient to remove any evidence of non-proportionality. So that's quite a powerful feature. You don't necessarily need time-varying covariates to explain non-proportional hazards. Even just adjusting for baseline covariates can be sufficient. Very briefly, if any of you are interested, the methods that I've explained today are available in the multi-NMA R package. It can also be used to fit standard aggregate data NMA and IPD NMA too. It's quite a a general framework across all of these. Fits models in a Bayesian framework using STAN. You can fit a whole host of outcomes, likelihoods, and link functions. So hopefully anything you can think of. And of course, you can do the usual things that you'd want to in a meta-analysis or network meta-analysis. So you can fix some random effects models to look at heterogeneity, unrelated mean effects, and nose splitting models for inconsistency, and so on. And it's constantly under development. So if you have play around with it and you think, oh, I'd like it to be able to do this, or I found a bug, then let me know. And you can find out more at the website here on screen if you're interested. So wrapping up then, multi-level network meta-regression is a flexible and general method for synthesizing evidence from mixtures of individual and aggregate level data in networks of all sizes, and for a range of outcomes, including survival outcomes, which we see very often in practice. It has several advantages over previous population adjustment methods. It works in networks of all sizes. It doesn't incur aggregation bias, etc. And crucially, you can produce effect estimates in any target population of interest to decision making, which is really important and something that isn't offered by earlier methods. That's it from me, just leaving you with some references there if you'd like to learn more, but I'm very happy to answer any questions and have a chat. Thank you very much.
Thank you so much.